Dr. Richard Krasuski from Duke University. Today we're going to talk about aggressive medical therapy of pulmonary hypertension and really ask the question is, does it improve quality of life and prevent negative patient outcomes? And we're going to focus in on the negative outcomes of quality of life, hospitalization, transplantation, and death. So in this slide, we're looking at the SERAPHIN study. And remember, this is a randomized controlled trial looking at Macitentan versus placebo in either patients who are on baseline therapy or who were treatment naive. And here is the quality of life data looking at the SF-36 scoring. And you can see that in the majority of the patients who received Macitentan, either 3 or 10 milligrams, they had significant improvements in their scoring when we looked at it compared to placebo. You can see in most of the cases there was a clear progression, a worsening of symptoms on placebo, where there was an improvement with medical therapy. Next, we're going to look at data both in AMBITION and SERAPHIN. This is looking at combination therapy, either initial or sequential, and looking at hospitalization. And you can see that there's a clear reduction in both the AMBITION study and the SERAPHIN study with the use of medical therapy in terms of reducing hospitalizations. On this next slide, you can see that there's a very important complications related to a hospitalization after discharge. So this is looking at an analysis from the REVEAL registry and looking specifically at patients who had a hospitalization. So here is the prospective analysis of 862 newly diagnosed pulmonary arterial hypertension patients. During follow-up, 57% had at least one hospitalization after they were enrolled, and 52% of these were pulmonary arterial hypertension related, and 3/4 of these occurred or had recurrences after discharge. Pulmonary arterial hypertension patients were more likely to be rehospitalized after their first hospitalization, regardless of the cause. And here you can see on the left the survival in patients with a first-time hospitalization from the time of discharge. And you can clearly see that a hospitalization is not a minor event in these patients. There's a clear reduction in survival from patients being hospitalized. So this is quite a morbid event here. And you can see that on the slide on the right here that survival for patients in the first year with no hospitalization was substantially higher. So again, not having a hospitalization is something that we should all strive for, is making sure our patients don't get hospitalized, particularly for an etiology of pulmonary hypertension worsening. So finally, I'm going to discuss the combination therapy of lloprost and sildenafil in a cohort of patients who were referred for lung transplantation. So here you can see there, in this particular cohort on the left, there are 5 patients. All of them were quite ill. They were all function class 4, and none of them were able to complete a 6-minute walk because of how sick they were. You can see that over time, combination therapy got them actually to function class 1 for one of the patients and function class 2 and 3 for 2 of the patients. You can see the cardiac index did stay the same or slightly improve in a few of the patients. And more importantly, only 1 patient ended up getting transplanted out of this cohort, so that actually there was a sustained improvement over time. So again, another potential improvement in outcomes by treating people aggressively with multiple therapies, in this case, an opportunity to prevent transplantation. So in summary, we've discussed the data suggesting that aggressive therapy appears to reduce the incidence of adverse clinical outcomes. We showed data looking at improvement of quality of life, but in addition to that, we showed data suggesting a reduction in hospitalizations, which are a substantially morbid event in patients with pulmonary hypertension, and also showed that potentially we can prevent a risk for transplantation. I thank you for your attention.